Okay, so welcome back to our lecture group on stroke etiologies and associated workup. As promised, now that you know how to differentiate the different types of etiologies of stroke, let's jump into the tests that we'll order to make these decisions. So first off, I want to talk about vessel imaging. So really every stroke patient is going to get vessel imaging no matter what. Um, Vessel imaging, as I talked about in the acute stroke lecture, is used in the acute setting to evaluate for thrombus and allows us to direct therapy such as TPA or thrombectomy. But it's actually also really helpful in helping us determine stroke etiology. So it helps us look for things like large vessel disease, as well as lots of other causes, including dissection, which you can see here on the right, vasculitis, vasospasm, and more. There's three main types of vessel imaging in neurology. Each of them have their own pros and cons, so let's talk about those. So CTA is the most common used vessel imaging that we're going to use. It's pretty ideal because it's very fast, so it's helpful in acute stroke care, and it's actually more precise than MR imaging. I discussed this more in the neuroradiology lecture, but MRA can actually overcall stenosis. The biggest downfall of CTA, of course, is that it comes with a hefty dose of contrast, and so it can be really hard on the kidneys. If you're really worried about a massive acute stroke and a patient with CKD, we're going to go ahead and proceed with a CTA anyway, knowing that we may be sacrificing the kidney to save the brain. But in the non-urgent situations, sometimes we'll use an MRA, or we'll use MRA. It'll be our preferred choice in a patient with CKD. And in fact, actually, MRA can even be ordered without contrast, and they just use physics to evaluate blood flow, which is pretty spiffy. Catheter-based angiography, on the other hand, also known as digitally subtracted angiography, or DSA, is a technique where we use a catheter and insert it into the femoral or radial veins, or radial arteries, much like in a heart cath, and then directly inject dye into the vessels of the neck and the brain. This is nice because it's the highest definition of vessel imaging available, so it really helps us evaluate for things like vasculitis or AVM or really subtle vessel changes. And then, of course, it also allows for access for interventional procedures like thrombectomy. Of course, the procedure has its own risks associated with it. It uses even more contrast than a conventional CTA. And of course, also there's a risk involved with any invasive procedure, such as a groin hematoma or actually even causing things like a stroke. And then finally, one important thing I really want to touch on here is that when you order imaging for the head and neck, you must order for the head and the neck separately in Epic. So for example, if you're placing an order, you must type both CTA head and CTA neck. For whatever reason, you can't lump these together, but please don't forget it. You're going to be sending your patient down for a second bout of radiation, a second bout of contrast, and you're just going to be delaying their care. Okay, so the next part of this workup we'll be talking about is MRI. I didn't include non-con head CT in this because it's assumed that every stroke patient up to this point has had one. But MRI is rarely ordered during the acute phase, and so often we discuss getting it during the post-stroke workup. Now, neurologists obviously love looking at brains. Nothing better than sitting back, grabbing a nice cup of coffee, staring at some beautiful brain anatomy. But that said, MRI isn't actually absolutely necessary to the post-stroke workup. If you're really confident in the stroke location and etiology based on your history, your exam, all your imaging, then ordering an MRI is redundant and can be cost effective to not get one. But this has to be a really clear-cut case. So something like a patient with known AFib, not an anticoagulation, who had a clot sitting in the right MCA on CTA and only has deficits associated with a right MCA stroke. That's really the only way you're going to get away without one. And given that we often opt for MRI, and the reason we do that is because it provides several benefits that a head CT does not. So for example, it can help elucidate the location of difficult to visualize stroke, such as lacunes or brainstem strokes. If you look here on the right, here you can see a left pontine stroke, pretty obviously on the MRI that's not seen at all on the CT. And then second, another thing is it can help you find second, smaller strokes in different vascular territories. And again, that'll lead you down a multifocal stroke differential like I talked about already. And then finally, MRI is just helpful to look for pretty much anything else going on, and also for a lot of those stroke zebras or stroke mimickers, things like encephalitis or demyelinating disease that are really just hard to see on plain old CT. So yes, with the right criteria, you can get away without ordering an MRI, and sometimes you may be forced to if patient has a pacemaker or other devices that are not MRI compatible. But pretty much more often than not, we're going to be getting an MRI as part of the post-stroke workup. Okay, take a breather. We're almost there. If you're about to give up, just know that Will is very proud of you, and here she is sharing her favorite toy with you. Okay, let's talk about cardiac workup and stroke. So as we discussed, cardioembolic strokes are a common and important cause of ischemic stroke, and thus every stroke warrants an appropriate cardiac workup. This includes rhythm monitoring for AFib, as well as structural evaluation to look for thrombus or PFO. So for rhythm monitoring, we have all stroke patients, no matter what, monitored on tele throughout their hospitalization. But if we have a patient with a cryptogenic stroke and we didn't identify an arrhythmia inpatient, then we need to proceed with outpatient rhythm monitoring. And again, the main reason is because we're looking for a cryptogenic, or looking for occult AFib as the cause of the cryptogenic stroke. One of the ways we can monitor this is with an event monitor, which is a somewhat bulky external monitor the patient wears for about 30 days. If they don't want to put up with this, they can instead wear a Zeo patch, which is a pretty slick EKG built into a sticker that they wear on the outside of their chest for a couple weeks. Both these are pretty good at evaluating for occult AFib, but the gold standard really is a device known as the loop recorder, which is what we pretty much always use here at UC. So the loop recorder, as you can see here in the picture, is a small device that's implanted subcutaneously in the patient's chest. It's a minimally invasive procedure. It happens really quickly, and the patients, after they have it, really never notice that they have the loop in. The nice thing though is it can constantly transmit EKG signals really until battery death several years out. So you can use it to evaluate for occult AFib nearly indefinitely. And then in regards to structural evaluation, we obtain a transthoracic echo, or TTE, pretty much in every patient. Specifically, we'll get a TTE with bubble to be looking for a PFO. Often a TTE is sufficient for evaluation, but there are certain patients where we say we're not satisfied with a negative TTE, and that's because being an external procedure, it's not completely sensitive for thrombus, especially in the left atrium. So given this, we'll often pursue either a transesophageal echo, or TEE, or a cardiac MRI in patients who we really have a high suspicion for cardioembolic stroke. So that includes young, healthy patients without obvious risk factors, or those we suspect for endocarditis, so people like IV drug users or patients with bacteremia. Okay, and the last part of the stroke workup is the labs we order. So any patient that has a stroke is going to get risk stratification labs, which evaluate for treatable causes of all strokes. So this includes an A1C, a lipid panel, a urine drug screen, and then sometimes a TSH, looking for hyperthyroidism that could cause AFib. And then further workup depends on if you have a high suspicion for other systemic disease. So, for example, we're going to pursue hypercoagulable workup in patients with multifocal strokes, or if they have other systemic clots such as a DVT, or in young healthy patients, especially say a young healthy woman who has a history of miscarriage. Hypercoag workup includes checking for factor V, prothrombin, protein CNS, a couple others, but most importantly, we have to check for antiphospholipid syndrome, and that's because this is actually the #1 cause of primary hypercoagulable related stroke. Furthermore, you should always consider malignancy as a source of hypercoagulability, especially in the elderly or people with concerning history such as weight loss or night sweats. So in order to evaluate for occult malignancy, we either do a quote-unquote pan scan of the chest, abdomen, and pelvis, or sometimes we'll actually jump straight to a PET scan if the suspicion is high enough. And finally, while they're rare, there are autoinflammatory and infectious causes of strokes. So if you start seeing or hearing a history of bizarre constellation of symptoms, things like fevers, night sweats, rashes, joint pain, kidney disease, anything that kind of gives that autoimmune or infectious vibe, consider ordering ANA, ANCA, ESR, or an LP to rule out these conditions. So that's it. We do a lot in the post-stroke workup, but it's actually pretty algorithmic and can be fairly straightforward once you master it. So to summarize, every patient gets some sort of vessel imaging, usually a brain MRI unless it's a super straightforward case. Cardiac rhythm monitoring with tele, and then also an outpatient loop, Zeo patch, or event monitor in cryptogenic stroke. We get a TTE for all patients and a TEE, or cardiac MRI for high suspicion of cardioembolic stroke. We get risk stratification labs with an A1C, lipids, UDS, and sometimes a TSH. And then we'll get a hypercoag or autoimmune/infectious workup if appropriate. And that's it. There's a lot in these 2 lectures, but if you understand them well, you're really going to be able to take care of a large proportion of our inpatient service. So let's go through a couple of questions to highlight some key points from the talk. Okay, so question 1. 78-year-old male presents with a stroke and has MRI findings as seen on the right. Which of the following risk factors would be unlikely to be the primary cause of stroke? Answer here is D, hypertension. So again, the key to this question is understanding the concept that hypertension, while a cause for all strokes, is primarily associated with small vessel disease. Small vessel disease presents with subcortical strokes, and so a more cortical stroke, such as this one, would be more likely to be seen in large vessel disease, or cardioembolic stroke, or endocarditis, or hypercoag states. Alright, so next, an 85-year-old nursing home resident with a history of left MCA stroke 4 years ago presents to the hospital with right-sided weakness and tells you, "I am having a stroke because this is exactly what happened last time I had one." A CT and CTA are unremarkable, and a UA is positive for large leukocytes and nitrates. The next best step in management is antibiotics. So this is recrudescence. So the key to understanding this question is knowing that she's having the same exact deficits as she did in her previous stroke, and this is in the setting of a new infectious or metabolic insult such as a UTI. Furthermore, CT and CTA imaging are unremarkable. So treating the underlying condition, in this case with antibiotics, should result in complete resolution of her neurologic symptoms. Okay, next question. Why do all ships in the Norwegian Navy have barcodes on them? Any thoughts? So when they return to harbor, they can scan the Navian. Scan the Navian. Alright, a 79-year-old with a history of diabetes, hypertension, hyperlipidemia, CAD, HFpEF, and an 80-pack years smoking history presents with a large left MCA stroke. His inpatient stroke workup is relatively unremarkable, includes clean intracranial and extracranial vessels, TTA with no findings beyond known heart failure, telemetry readings only showing sinus rhythm. So what's the most important next step prior to discharge? Answer here is D, place a loop recorder. So this is a cryptogenic stroke, given the fact that there's no discernible cause for this large cortical stroke, especially in a patient who has every risk factor in the books to have AFib. So in these patients, you must pursue further cardiac rhythm monitoring to evaluate for a cold AFib. This includes event monitor, Zeopatch, or the gold standard, a loop recorder. So how about this case then? This is the exact same scenario, but instead of a 79-year-old guy with a ton of risk factors, we have a 42-year-old with a history of GERD. What's your next step here? A, pursue a TEE. So this is an example of one of those patients with a cryptogenic stroke who we would not be satisfied with a normal TTE. These patients include young healthy folks without risk factors, or people who we suspect endocarditis in, such as drug users or bacteremic patients. In these patients, it's important to obtain more sensitive cardiac structural evaluation, so we either use a TEE or cardiac MRI. Alright, last question. Match the following stroke subtypes with typical appropriate secondary prevention. I'll let you know that some of the options on the right apply to more than one subtype. So maybe pause the video real quick, attempt to match these, and then we'll go through them together. Okay, so let's take these one at a time. For large vessel intracranial disease, we use B, dual antiplatelet therapy, as well as F, high-intensity statin therapy, and G, control of risk factors with tobacco cessation, blood pressure, and glucose control. Alright, next subtype is large vessel extracranial disease, and for this we use E, carotid endarterectomy, or carotid stenting, as well as a high-intensity statin and risk factor control. For small vessel disease, we use D, weight-based aspirin, plus a high-intensity statin and risk factor control. You're probably seeing a trend here. Next is cardioembolic stroke, not counting endocarditis. Remember, endocarditis should not be anticoagulated. It should be treated with antibiotics. But the rest of cardioembolic stroke should be A, anticoagulated, and then again given a high-intensity statin and have the risk factor control. Up next, we have the famous cryptogenic stroke, which we treat with so cardiac rhythm monitoring, as well as weight-based aspirin. Remember, we may one day anticoagulate these patients, but right now the literature is still up for debate. And then, of course, these patients also get a high-intensity statin and risk factor control. And then last but not least, we have hemorrhagic stroke. And unfortunately, we don't have great treatment for ICH at this point, but it really comes down to controlling risk factors, specifically blood pressure. That said, don't forget that high cholesterol may actually be protective in these patients with ICH. So if they have an isolated ICH, you actually don't really need to place the patient on a statin unless they have other reasons, such as a history of ischemic stroke or cardiac disease. So you can see here, every stroke patient is going to get a statin unless they have a hemorrhagic stroke, and then every stroke patient, no matter what's, going to get risk factor control. And then that's really it, guys. So now you kind of know the foundations of stroke etiology and how to work it up. All right, see you next time.